Up next, a very, very interesting topic for all of us, I'm sure. Decoding medications, biologics, painkillers. There's so many different things that we are exposed to, and I don't think we always understand exactly how they fit into the picture and what they do. So, Dr. Joyce Ziki is kindly joining us today to shed some light on this. She's a specialist rheumatologist whose career began in Zimbabwe, where she obtained her MBCHB degree and completed her internship and community service. In 2012, she obtained her specialist qualifications from the University of Witwatersrand and the College of Medicine SA. She subsequently joined Tembisa Hospital in South Africa as a specialist physician before returning to Charlotte Maxeke, I'm not saying that right, I'm sure, Johannesburg Hospital for further training in rheumatic diseases. In 2018, she qualified as a rheumatologist. Dr. Ziki is currently an honorary lecturer in the Department of Rheumatology at the University of Witwatersrand, where she is pursuing her PhD and is an active member of SARA. Her areas of interest include systemic lupus, systemic sclerosis, inflammatory myositis, precision medicine in inflammatory arthritis. That includes gout, rheumatoid arthritis, ankylosing spondylitis, and the use of technology in the management of rheumatic conditions. Dr. Ziki, over to you.
Okay. So you all know me. I'm Joyce Ziki. And yes, I'm practicing in Johannesburg with a satellite clinic in Secunda. And this talk really, I've been asked by the expert team to give an educational talk on how biologics work. And it's really not for marketing. I may use a specific trade name for drugs, but it's just for ease of discussion and for ease of reference. And I'm going to limit my talk to inflammatory arthritis. And this does not constitute any medical advice. It's really for education. So my talk or the ask was to answer the question, how do biologics work? And I will try and answer as many questions as I go related to biologics. And the starting point is, why do we even need these biologics? So the reason is we get immune system dysregulation, which then constitutes an entity called autoimmune conditions. They do not have a cure. We as rheumatologists manage the condition, aim for remission, and remission is currently the buzzword in rheumatology. And what does it really mean? It's basically, for me, it means having a happy patient who's fully functional and symptom-free and who can get along with everything they need to do in life. And on the clinical aspect, we do have a lot of scores that we used to define objectively this entity called remission. But that is what we as rheumatologists are striving to do when we manage inflammatory conditions. And the tools we use, or the armamentarium we use to achieve remission, are basically what we call DMARDs, or disease-modifying anti-rheumatic drugs. And in simple words, it's basically medication that change the course of the disease instead of us resulting in damage, which is the degeneration we've been talking about earlier on. We try and preserve the joints and we do not have degeneration and we do not end up with joint replacement or joint deformities. So that's what we're basically trying to prevent. And in the past, we've had synthetic DMARDs, and then later on in the 90s, biologic DMARDs came through. And most recently, within the last 5 years, we've had the small molecules, which include the JAK inhibitors mainly. And these DMARDs, like I said, you can move to the next slide. They basically are three main entities that we talk about when we talk of DMARDs, which is the synthetic, biologic, and small molecules. And the synthetic DMARDs are your methotrexate, cilazopirin, leflunomide, cyclosporine. And these are really chemical in nature, manufactured in the lab, and their chemical structures, they're easier to manufacture, they are cheaper, they can be quickly produced, and hence you find they are more affordable versus the biologic and small molecules. And you find with the synthetic DMARDs, they are targeting the immune system or modulating the immune system at a broader spectrum, at a broader level, while the biologics are more targeted. They are controlling the immune system through specific molecules. Tanya, you can move to the next slide. Mm. Miranda?
I'm here, Dr. Ziki. I'm just hold
she,
on.
She can move. Oh,
She's gonna move it down now. I think she's just
okay.
battling. Just
Oh,
give
yeah.
her a second.
Which slide do you want, Dr. Ziki?
I think we're on must be on the 5th slide now.
This one?
No, the next one.
How are they made? That one?
So you're still on the background, and there's the DMATs, the next one.
DMARDs, the synthetic DMARDs, then it's biologics. What are they?
Yeah, so you
Tanya,
can move.
the screen's frozen, so maybe you
It's
can just go
frozen.
in and out again. Yeah. Sorry, Dr. Ziki. The gremlins are here.
It's okay.
There we go, Dr. Ziki.
Okay,
There we
thanks.
go.
So basically, I mean, I've just been giving a background of DMATs, synthetic. I've described the synthetics and then the biologics, which is the main crux of this talk. So biologics are large molecules. They are protein in nature, and they are synthesized in cells or organisms, hence the name biologics. And they're expensive to produce. And because it's a protein, when one injects a biologic, the body then after some time recognizes that there is a foreign molecule that comes in every 2 weeks or every month, and then the body starts forming antibodies against this protein to get rid of it. And that's how sometimes we end up losing efficacy of our biologics. And they are targeted, and the ones we're going to talk about today, they mainly target cytokines and immune pathways in the immune system. Next slide. And so these biologics, like I said, they're expensive because of the process of production. And it's called biomanufacturing because we're manufacturing a protein that mimics molecules in the body. And it involves living cells, hence the bio part. And once they've expanded these cells, they are then cultured and multiplied, and then they are made purer through centrifugation and purification. And then before they are given to the patient, there's an analysis for uniformity. And while we are talking about uniformity, these protein molecules are large, and sometimes you may find that there is batch-to-batch variation of the biologics. So you inject your biologic this month, and then you find the one you received 3 months down the line, you get a skin reaction and you wonder what's going on. It's because you find that the biologic or the molecules are not the same. So one batch may be different from the other. And as a receiver of this biologic, you may then form in reaction to it or not tolerate it. And usually I then tell my patients, just wait for the next one and let's see if this problem persists. And sometimes you find the problem doesn't persist. So it's related to how they are produced and their large nature and that they are proteins. Next slide. And this slide just basically summarizes the biologics that we have in South Africa. When we discuss biologics, we look at them in two broad arms. The anti-TNFs and the non-anti-TNFs. Reason being that the TNF family was the first group of biologics to be made. And within the TNF family, infliximab is the first biologic that was made, and then adalimumab. And adalimumab is the most commonly used biologic. I think in South Africa, we've got Humira and its biosimilar Amjevita. And then we've got the anti-TNFs, which is abatacept, rituximab, and tocilizumab. And anti-TNFs are commonly used in axial SpA, but the non-anti-TNFs, abatacept, rituximab, and tocilizumab are not. And the next slide. The next slide does give other non-TNF biologics that we use in axial SpA, and these are our interleukin-17 inhibitors, that's Cosentyx and Copella, interleukin-23, guselkumab, and then Stelara, which blocks IL-12 and IL-23. So these are the non-TNF biologics that we use in XSpA. And then we have the small molecules. These are the new kids on the block. There are three main ones currently in South Africa, and these are available in tablet form. They're cheaper to produce, should be cheaper to the patient, but they are still quite expensive at the moment. And as you all know, Xeljanz is the cheapest, coming in at 3,000 Rand. And these target specific pathways within the cell that result in formation of cytokines, and thus block multiple cytokine pathways. So I'll discuss this next. Next slide. Okay, so taking a step back, what's wrong when one has an autoimmune condition? So basically what has happened is things have really gone wrong in the body. The immune system, which is supposed to be the watchdog, the protector of the body, has gone AWOL, has become dysregulated, and has begun to harm self. So self-regulation has been lost, and order is lost. There's chaos in the immune system. So these are some of the words that describe what is happening when one has an autoimmune condition. And the internal defense system, which is supposed to defend self, ends up attacking self. So hence the immune dysregulation. And while this immune dysregulation is going on, there are a number of players in the body that are involved. So it is the cells of the immune system. And commonly, as you read, you'll find they talk of B and T cells. And then there's also cytokines that are released. And these cytokines are basically the communicators, the communication system in the immune cells that tells the immune system how to behave. So for example, if the B cell is dysregulated, it then produces certain cytokines that go on to the next cell and tell the next cell that, okay, this is what we are doing. We are now going to damage the skin. We are now going to damage the eyes. We are going to damage the back. And this is done through the cytokines. And the cytokines get to the effector organ, which is the joint or the skin or the eye, and they cause problems. And one then presents with organ damage, or one then presents with symptoms, and then we make a diagnosis of an autoimmune disease. And for us to restore this immune dysregulation or chaos in the immune system, we use the DMARDs to restore that. And then hence the different DMARDs I've talked about earlier, the synthetic, the biologic, and the small molecules. And you can go on to the next slide. And if you want to think of it, that if you look on that intersection, that this is what has gone on, there is chaos in the body. And when we bring in these biologics, we bring in the DMARD, the synthetic DMARDs, we're trying to restore order at the intersection so that things flow nicely. But in that flow, we have not taken away the cars. So the immune system cells are still there, but we've just regulated them. And this also talks to the reason why we don't have a cure for this disease, because we're not taking away the immune cells, but we're bringing order. And when order is restored, there is homeostasis, there is harmony, there is happiness, and the patient is happy. No organs are being damaged. And this is how we use the DMARDs. We can move on to the next slide. And then the question is, what is actually happening in the immune system when we've got dysregulation? So this is a very busy slide, but just to illustrate what is actually happening in the body when we say we are diagnosing someone with axial SpA, we are diagnosing someone with rheumatoid arthritis. There's cytokines that are being released, there's organs that are involved, there's cells of the immune system that are involved. And you can see your IL-23, TNFs, IL-17, and it's not just one molecule that is released when one has a specific condition. You can have all these cytokines flowing in the body and causing havoc. And when we come in with the biologics, we are trying to target pathways, and we are trying to target these cytokines so that their production stops. So the cytokines are no longer there, because these cytokines are abnormal and they are communicating information that should not be communicated in the body. So the aim is to stop their production, to get rid of them, to block pathways that produce these cytokines. And that is why you find when people talk about biologics, there's always that buzzword, cytokines, cytokines, cytokines. And that's the reason we keep talking about the cytokines. And at the moment, the talk is which one comes first. So when the immune system is dysregulated, which one is a downstream, which is upstream. So if we block a downstream cytokine, can we block the successive cytokines, or do we block an upstream cytokine? So it's like a cascading pathway. And what we are doing with these drugs, we are trying to stop the pathway at different levels. And sometimes, like you can see this chaotic slide, we come in with TNF, but the IL-17 is still there causing harm, still causing backache, but we've blocked TNF with Humira. So then we change our blockade and go and block IL-17, but IL-23 is still there. Then we try using gelzukimab. So that is why you find there is this switching of cytokines. Because as a rheumatologist, when a patient is sitting in front of me, I do not know which cytokine is dominant at any given time. Is it IL-23? Is it IL-17? Is it IL-12? So I try and look at the patient's symptom, the patient's presentation, and postulate that, okay, if one has skin and back and joints, which biologic in clinical trials has been shown to cover these symptoms well? And then you find, okay, let me use an IL-17. And you apply for IL-17, and Discovery comes back and says, no, 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 no. We're not going to give you IL-17. We want to give you a TNF because it's cheaper. But in my mind, the cytokine that I would have thought would be best for a given patient would be an IL-17. So we use a TNF. So again, that is why sometimes we have to chop and change these biologics. So this slide just depicts what's going on in the body. And this is what we as rheumatologists are trying to figure out when we are looking at you and sitting in front of us, complaining of backache, complaining of psoriasis, complaining of uveitis, complaining of nail changes or gut problems. This is what goes through our minds. Next slide. And again, this cartoon just shows how the immune system works. We have the immune cells that I alluded to initially. And these immune cells, once they are triggered or a stimulus comes through, be it genetic predisposition, be it an infection, be it other triggers that can come through, or even like this morning, I had a patient who has been on immunotherapy and he's now got inflammatory arthritis. So other drugs can trigger this immune cell. And once this immune cell has been triggered, it produces the inflammatory molecules. And the inflammatory molecules are what constitutes the different cytokines that I just showed earlier on. And those cytokines are what the biologics are trying to block. So when cytokines are released, they go to the target organ, which in this cartoon is the joint. And when they get to the joint, or when they are released in the joint, there is pain, there is swelling, there is loss of function in the joint. And we try and restore that function by using the DMARDs. And we can move on to the next slide. And why are these biologics referred to as targeted treatment? So unlike methotrexate, so methotrexate goes and blocks the cell cycle. So it blocks this abnormal cells that are proliferating and producing cytokines. So when we give methotrexate, we are stopping cell production. We are killing the cells, in other words, and hence methotrexate's use in cancer cells, in cancer treatment, because we are trying to get rid of abnormal cancer cells with methotrexate. In terms of rheumatology, we are trying to get rid of abnormal cells of the immune system. So we block the cell cycle. But in terms of biologics, which are more targeted, we are now trying to block a cytokine. So IL-17, TNF, interleukin-23, we go and literally block them. And once we block them, then they don't go to the organ and cause problems. Or we can block the pathway in the cell that results in the production of cytokines. And that is where the JAK inhibitors work. So the JAK inhibitors basically block the pathway that results in cytokine production. The biologics block the produced cytokines, either the cytokines that are circulating in the body, that is what the biologics block, or the biologic can go and block the receptor. So for the cytokine to give its effect, it has to bind to a receptor found on these cells. So you may find the biologic goes to block that receptor, and that's how our etanercept, which is commonly Enbrel or Erelzi work. They block the receptor for TNF. While Humira, adalimumab, infliximab, they block the TNF that is circulating in the body. So that is basically how these biologics work. They block the cytokine circulating in the body. Next slide. Again, this just tries to describe what these cytokines are all about. You get a stimulus to one cell in the immune system, and then that cell, once it is irritated or it's made unhappy or it's dysregulated, which depicts, it becomes dysregulated, which is the intersection I showed, and then the cytokines are released and they go to an organ and cause symptoms. So we come in and block these cytokines, and there are different types of cytokines. And the cytokine produced depends on the condition. So certain conditions, you'll find certain cytokines. So for example, in rheumatoid arthritis, you've got your TNF, you've got your IL-6. You do not have interleukin-17 or interleukin-23. That is why we cannot get good results, or we do not use, for example, Cosentyx to treat rheumatoid arthritis, because interleukin-17 is not part of the disease process of rheumatoid arthritis. And that is why you find then that is where the challenge comes, that the funder says, okay, we will fund for TNF for rheumatoid arthritis, but we will not fund Humira for axial SpA. But at the end of the day, it's the same molecule that is causing problems. So the TNFs tend to be found in both conditions, but IL-17, IL-23, they are more targeted, or cytokines common in the spondyloarthritis. Hence, we don't use these molecules. So that's basically what cytokines are. They are the main players in the immune system. And this slide basically depicts the different cytokines that are associated with spondyloarthritis. So you find with spondyloarthritis is divided into axial and peripheral. And you find that in axial SpA, there is interleukin-23, interleukin-17, and interleukin-23 and 17 is also found in peripheral SpA. So these two cytokines are common in spondyloarthritis, with TNF being found in both. So TNF is like the most common cytokine in both in inflammatory arthritis. And then these are the different blockers we have for the two conditions. And again, the other diagram on the left shows what happens, that when the cell is unhappy or has been stimulated, it does release TNF, IL-22, and IL-17. And these molecules go into the different parts of the body and cause inflammation. Inflammation being the pain and the swelling. And they are also released in the spine. And in the spine, they cause inflammation, which then presents as backache for axial SpA. So one comes in with backache, which is described as inflammatory, below the age of 40. They are probably HLA-B27 positive, gets worse in the morning and gets better as you start moving. But what's triggering all that, what's behind those symptoms are the cytokines. And hence we try and block the different cytokines. And unfortunately, I cannot tell what cytokines, like I said before, are dominant in each patient. So hence the trial and error that comes in treating rheumatological conditions. So when your rheumatologist chops and changes your biologic, it's not that they are incompetent. It's just that this disease is complex and we don't yet have the tools or the biochemical tools for one to predict. It would be nice if a patient could walk in and say, and I diagnose axial SpA, and I say, okay, take your blood sample to the lab, let them give me your cytokine profile. And then when we've got that cytokine profile, then I'll say, okay, IL-23 is the dominant one. Let me give you guselkumab. Or IL-17 is the highest. Let me give you Copella or Cosentyx. Or no, it's a TNF that is high, so Humira will work for you. So we don't have this. We are forced to make a clinical decision based on the phenotype, on what I see clinically. But what I see clinically does not correlate with what is happening at a cellular level. It does not correlate with the cytokine. You can move to the next slide. And again, I always get this question from my patients: why are you giving me methotrexate? Why are you giving salazopyrin? Why not just give me Humira, or why not just give me Cosentyx or guselkumab day one? And we do not do that for various reasons, because these biologics are not perfect, they are expensive, there's a funding model, unfortunately. And most patients, if they present early, are diagnosed early, they do well on the synthetic DMARDs. So like in my practice, most of my patients are on methotrexate, salazo, leflunomide, or a combination, and they are doing well, and we do achieve remission. It's only maybe 10 to 20% of the patients whom we fail to achieve remission with the synthetic DMARDs, and then we move to the biologic DMARDs. Next slide. And I've just tried, I thought this was going to be a virtual talk, so I just tried to preempt and answer and give a few questions that I commonly get asked. The first question is, why do I have to take them for the rest of my life? So the reason is there is no cure, and the immune system forms what are called memory cells. And these memory cells, they do not go away, they remain in the body. And I always want to use HIV. People with HIV keep taking their medication, they look well, they are well treated, viral load is undetectable, but stop the ARVs, the viruses start replicating, the patient becomes symptomatic, because they are memory cells, T memory cells that are formed in HIV. And the same happens with these autoimmune diseases. We can only achieve remission, but we cannot take away those memory cells, those abnormal memory cells that remain lingering in the system. Hence, it's lifelong, and why we can't cure. And why did biologic therapy fail? I tried to answer this. So one is because the body forms antibodies to the protein, or the patient is non-compliant, or we are targeting the wrong molecule because we do not have an initial bioanalysis of the cytokine profile. So I may be giving someone Humira whose dominant cytokine is interleukin-17. So clearly this patient will not do well, and then that could be the other reason I have to change the biologic. Or we've completely missed the diagnosis, I've made a wrong diagnosis, so I need to take a step back and re-evaluate my patient. Next slide. And then why will I get the same side effects as I had on methotrexate and salazopyrin? So because of the targeted nature of biologics, you find that the side effect profile is a bit gentler. The main one being tuberculosis, infections, and injection site reactions. And with the salazopyrin and methotrexate, it's like a broad spectrum, broad approach. And the one analogy I usually use is like if you've got a garden and you've got weeds in the garden. When you're using methotrexate, you want to get rid of the weeds, but you may end up killing some of your vegetables or some of your flowers. But with biologics, you're going specifically to root out the weeds and you leave your vegetables intact. So that is why you find that with methotrexate, salazopyrin, the side effect spectrum is broader, because it's a broad spectrum approach. And the other question is, why don't we start with biologics instead of synthetic DMARDs? Again, the reason is it's cost effective, and not everyone is going to respond to biologic, or not everyone is going to fail the synthetic DMARDs. Next slide. Oh, that's the end.